What's up, guys? Dr. Mo here, Mohammed Ashori, MD. I'm a board-certified family medicine physician. Welcome to Digital Nomad Health. So a question I get asked by fellow physicians is, why is it that my medical practice doesn't have malpractice insurance? Why don't I purchase malpractice insurance for my medical practice? And so let me explain, because this is intentional. Most medical practices, the traditional mainstream insurance-based medical practice, basically functions off of volume. There's a lot of patients that are sent by the insurance company to the provider, to the clinician, to the physician, to the medical office. So in a way, the marketing source, the top of the funnel, is the insurance company. And they do that by contracting directly with the employer often. And the employer then entices the patient to be part of their workforce by giving them really good health insurance. In some ways, this is good. In some ways, it is bad. It is good in the sense that expensive healthcare cost, the health insurance premiums, can now be paid by the employer. The downside with that is you are going to see a big rise in the overall cost of health insurance over time because the employers are in charge of it. It's not the patient that is in charge of it. And so there isn't as much emphasis on making sure that it is affordable and meeting the needs of the patient. It often instead ends up meeting the needs of the employer. And those aren't always they're not always clashing, but they're not always in line either. In my own medical practice, well, I decided that the patients I'm going to see, it's going to be a mutual decision to be in the same relationship together. Meaning that the patients find me from word of mouth or from my online advertising or the content that I write, and they say, "Hey, Dr. Ashori, I like you. I like your style. I think, we have the same philosophy and I'd love to be your patient." And at the same time, I get to sort of interview that patient and decide if they're the right fit for me, because whether I'm a good physician or not, I'm only as effective for a patient as they are willing to listen to me and understand me and see me as somebody who can help them. If we both don't see eye to eye, if we don't have the same personality traits or similarities, then we're never going to be a good fit. I could be the best doctor in the world, I could be the worst doctor in the world, and it's just not going to work. And on some occasions, it might be that the patient's difficult, as many physicians say. It was a very difficult patient. It was they were a poor historian. We have this terminology, not so much because the patient was bad, but because they had characteristics that just didn't mesh well with who I am as a physician. One thing that I always like to tell my patients is, look, this is going to be a relationship. It's going to be like husband and wife, and husband and husband, wife and wife. We're going to have to put some effort into it, and we're going to have to keep it fresh, and we're going to have to keep it young. And I got to put in the work by understanding you and researching clinical medicine as it evolves. And you got to put in the effort by doing the things that I say. So in this kind of relationship, it's not the type where the patient comes to me and says, "Hey, I need an antibiotic for this," or "I got this chest pain, I have no idea what it is. You figure it out." That's not a good relationship. That's not the type of patient-doctor relationship in which I will thrive. And when I don't thrive, my patient won't thrive. Instead, it's much better when the patient comes and says, "Hey, can I run something by you? I want to get your opinion." And they expect me to educate them, to empower them, to give them some information, to guide them. And then, when absolutely necessary, to prescribe something or recommend a certain intervention. That is a good relationship. These are the great kind of relationships that I want to build in my practice. I have about, 150 slots available for that. Anything more than that, I think, will be beyond my capabilities. Currently in the United States, there are probably about 300,000 physicians who are in primary care, doing purely primary care, and there are probably about 300 million adults in the US. So when you do the math, somewhere around 1,000 adult patients to 1,000 primary care doctors. And that doesn't take into account all of the physician assistants and nurse practitioners that are out there. So in reality, it's quite feasible for a physician. A mainstream insurance physician usually has a panel of about 2,500 to 3,000 people. So for the people who are comfortable, for the patients who are comfortable in that kind of setting, they can go to a standard insurance-based practice. For others who really need this one-on-one attention, there are people like me, and by keeping my numbers low, I get to give that patient an individual attention and grow the relationship and hopefully become the kind of practice where somebody's not really out to sue me. I'm not making as many mistakes. And for that reason, the need for insurance coverage for malpractice insurance goes down. Of course, if there is a bad outcome, I want my patient to have a right to be able to get some sort of remuneration for whatever, God forbid, bad thing happens. However, because it's sort of a shared decision-making model, even the responsibility kind of falls on both of us. And that's why I have an arbitration agreement with all of my patients. And should something bad happen, we will go to a third-party arbitrator, present our case, and both of us hopefully will get some fairness out of it, and maybe we'll continue working together. And perhaps not. That's just the nature of it. I hope this is helpful to you. Leave some comments below. Let me know what you think. And how do you see yourself dealing with a major medical mistake in your care? What would you do? What would you want to have done? Take care, guys.